invite Dr. Aniruddha Maiti. Okay. Best wishes for your happy journey. Thank you. Dr. Aniruddha Maiti is the director of Global AI Hospital, and he will talk about few of his longest day cases.
Thank you, Dr. Boral, for giving me this opportunity. Well, in VR surgery, any surgery can go long hours, sometimes planned, sometimes it is not planned. So I will show two cases where the first case, it was a simple case of vitreous hemorrhage, and the second case is a traumatic case. So can we just play? So it was a dense vitreous hemorrhage. When we advised this patient, it was a subhyaloid hemorrhage, but the time this patient came, it was quite a dense hemorrhage, and you can see a well-defined sub-ILM bleeding behind this dense hemorrhage. So after doing the vitrectomy, taking out this organized blood, we plan to remove the ILM. Generally, these cases do pretty well. The vision improvement is also very good from the very next day itself. So I thought I will just peel the ILM, flush out the blood, do some peripheral dissection, check out the periphery and close it. So that was the plan. Just trimming the vitreous base, you can see there was a lot of hemorrhage. Now, can you pause? Now, something happened after I did this ILM peeling. This patient had a bout of cough, and the patient literally sat on the table. And once the patient was again reinstated in the operative position, you can see through the cannula, obviously this cannula, although valved, it leaked, and this is the spot of blood came out. And can you play it again? Now this time the case became even more difficult. It was easier case before to start with. Now it landed up into suprachoroidal hemorrhage. There was a superior RD. Actually, we had to pass the instrument through the suprachoroidal space, and the hemorrhage, you can see it again. Fresh hemorrhage is a little bit difficult to take off. So I had a difficult time. It's in a video, edited video, but it took really long time to remove this fresh bleeding. And it was so difficult to introduce the instrument from that port where the suprachoroidal hemorrhage has happened. We had to go to the other side, other port, did the fluid air exchange, and with the other side of the other port we had to complete the laser. But doing the laser also, we had certain areas was beyond, we could not do laser, so did some cryo. Ultimately, which was a simple case, land up into a long day, and in the end it went well. The vision improved to 612. Now this I had expected that this trauma cases are full of surprises. This was an exploration, had an injury, a very typical injury, atypical injury I would say. The fan fell into the head as well as the side of the eye, and obviously the globe rupture, it was an exploration, and we saw the globe rupture. And the globe rupture extended beyond the muscles. So we had to disinsert the rectus muscles, and then we could access this is the disinsertion process. And once we disinserted, we could access the rupture, which actually had a long extension. now we can easily suture this part. Now, this patient had a head injury, so the patient was actually in the hospital, in a multi-specialty hospital for 2 weeks. But in the ultrasonography, although it was very disorganized, but we could make out there is a detachment. So instead of a double stage procedure, we thought we will do, and a single stage operation, we cannot leave the RD for a long time. So once we remove the hyphema, because we saw that the lens needs to be removed, otherwise it was difficult to, the visibility was extremely poor, there was detachment, there was vitreous hemorrhage, there was suprachoroidal as well as the choroidal rupture. So we decided to remove this lens, and at least we can access the posterior chamber easily. And this was a traumatic case. We had expected this is going to take long, so the patient was in general anesthesia. And otherwise, local anesthesia in this case becomes very difficult. So once we removed the lens, then put a AC maintainer, because I mentioned that there was a suprachoroidal hemorrhage as well. Now it was all mixed up, blurred retina. So with a lot of patience, first step by step remove the bleeding. You can see the underlying, that's the choroidal rupture. This is the choroidal rupture area. Now once the hemorrhage, once it was removed, we could make out the extent of detachment. And very carefully trim the blood. Now put PFCL. So once the posterior pole is stabilized, we can actually work on the periphery. 1 minute. Now we can see the disc and the vessel posterior pole become little bit clean. We could not do the subchoroidal drainage because we had just repaired the wound and the eye was hypotonous. It was difficult. And you can see we could do the laser and then did a silicon oil PFCL direct exchange. That's the last bubble of the PFCL. Ultimately, this patient did pretty well actually, and I'm very happy because he has also lost hope because he thought that it's gone. This was a very bad injury, and ultimately, from perception of light, this patient turned out to be 624. So this was 2 different cases with a lot of patients, and obviously due to this good viewing system, we can manage these cases and give a good prognosis. Thank you.
Excellent presentation. Dr. Devdulal, in question.
One thing is, like for the, when you give this under GA, general anesthesia, so do you give a little bit of a local anesthesia also in this? You
No, this was this was an open wound.
Yeah, that's why I asked. So difficult.
No,
So you had any, because the patient was under in a hospital, and I hope there were no cardiac issues. So because you did muscle disinsertion also.
No, we didn't give actually, because the fact we didn't give is it was all messed up, and it was an open wound.
Yeah.
So
So I was just
eye,
wondering, like after you had done half of the, just for like my sake I'm asking, after you had done half of the suturing, would it can we in certain situations can we do a, this is a question to all, some subtenon injection for in this kind of situation?
That can be a subtenon.
We can do, no?
Could have been given.
Yeah, basically, you have to be very ready with all kind of like situation, like you have to remove the cataract, and
Yeah,
anyway
it was
timing
like
is-
doing all surgeries,
yes,
squint and cataract.
just to make more maneuver intracollarly. Yes, Dr. Reddy.
Dr. Maiti, the first case that you said where almost you completed the
Yeah,
surgery,
yeah.
ILM, Valsalva maneuver, ILM peeling was done, and
Yeah.
then the patient became uncooperative. And
Yeah,
then this-
patient was during the ILM peeling also started coughing.
But I think the first thing was suprachoroidal hemorrhage in that
Yeah,
patient.
yeah. Suprachoroidal hemorrhage happened, and actually we didn't know what is there inside when he went
again.
inside for the second time, and I had to push my instrument inside, and then the RD actually that was an iatrogenic. So it was like iatrogenic on part of the doctor as well as for the patient.
If that RD had not developed, you could have just closed the case, I
Right,
guess.
right.
Yes.
No, the hemorrhage, the fresh hemorrhage also was there, and which settled in the posterior pole.
So where was the break? Is the disinsertion of the
There
like,
was
That
the
is-
break. RD was there near the insertion instrument. It was
Okay.
instrument induced.
Okay, thank you.
Just
Thank
one
you.
question. What if in case the patient had developed suprachoroidal hemorrhage and you had closed the surgery and maybe deal with it subsequently 2 weeks down the line? Would that be...
But it was not that extensive. It was
To begin with,
more
it
of
didn't look
basically
that
I
way.
didn't know what has happened inside. I realized when I went inside and there was suprachoroidal and I induced a detachment as well. So I had to repair the detachment and take out the blood.
But I think the courage on your part to operate on a patient who's already sitting up literally coughing vigorously to finish the surgery with all this is
I had to
creditable.
You have to complete.